Welcome to this INPCS poster showcase session. My name is Manon Auffret. I am a French pharmacist and neuroscientist working on Parkinson's disease in Rennes, France. Before I begin, I would like to thank the INPCS Annual Meeting Committee for giving us the opportunity to present our work on the management of terminal Parkinson's disease. I am presenting this study on behalf of my co-authors coming from two different but interconnected fields. Neurology with Dr. Mathieu Béraud, Professor Laurent Tatu, and Professor Marc Vérin, as well as palliative care with Dr. Mathilde Colombet-Giffard and Dr. Anne-Laure Clairet. Parkinson's disease is a chronic and progressive neurological disorder characterized by a great variability in terms of severity, symptom burden, clinical subtype, and disease progression rate. Its evolving layers of complexity ultimately leads to a high level of both physical and psychological needs and a loss of autonomy throughout time. Palliative care needs are increasingly recognized in Parkinson's disease, but not always met in clinical practice. Particularly, there are currently no recommendation for the therapeutic management of PD at the end of life. Only short reports or case series are available in the literature, highlighting either apomorphine use, deep brain stimulation continuation, or rotigotine patch prescription. Progressive or sudden inaccessibility of the oral route is frequent at this stage and may result in symptom resurgence, as well as complications such as aspiration pneumonia or the Parkinsonism hyperpyrexia syndrome. These potentially fatal outcomes considerably worsen the quality of life of PD patients and their relatives. Apomorphine appears to be of great interest in patients unable to take all medications due to its subcutaneous administration on one hand and its pharmacological properties on the other hand, acting as a potent dopaminergic agonist. The aim of our study was therefore to assess the interest of continuous subcutaneous apomorphine infusion in PD terminal care. We therefore collected retrospective clinical data from PD patients for whom apomorphine infusion was initiated in the context of terminal care, either in Rennes or in Besançon. We analyzed patients' comfort, drug consumption, antiparkinsonian, analgesic or sedatives, as well as caregiver burden when available. We also recorded side effects related to apomorphine infusion, such as subcutaneous nodules, nausea, or neuropsychiatric symptoms worsening. Here are the results of our 7 patients at the time of the analysis. We now have more patients to add to this series. You will be able to see this table and these characteristics in details in the poster PDF available on the website. Patients were mainly female, around 80 years old, with a diffuse PD phenotype and a mean disease duration of almost 14 years. They all exhibited red flags or end-of-life prognostic predictors, as defined by Akbar and colleagues, and terminal care followed precipitating factors associated with swallowing issues and erratic medical compliance. Apomorphine initiation resulted from a multidisciplinary discussion between neurologists and palliative care physicians. It was initiated at low doses, which improved pain, rigidity, and reduced caregiver burden. The short period of time between apomorphine initiation and death in all patients, as well as the previous chronic exposure to clozapine in 3 patients, may have facilitated the tolerance of apomorphine. It is important to note that we are not aiming at a motor optimum, but most aiming at a patient comfort with such doses. Apomorphine infusion is of great interest in PD terminal care as it reduces motor symptoms and overall discomfort with an apparent good safety profile. However, randomized controlled trials are still needed to establish its efficacy and tolerability, but also to compare it to, for instance, the rotigotine patch that is used in the UK, or DBS continuation, or maybe a new therapeutic that will become available in the future, for instance, subcutaneous levodopa. Thank you for your attention, and I'm available if you have any question.
Thank you very much indeed for that. Very interesting. As a result of this work, are you looking at a guideline for your local service? And how do we take this out more widely? Because I think there's a lot of concern and it would be useful to get this information more widely.
Indeed, thank you for asking that. This work is actually the following of a current study project that is undergoing at my university and a hospital, and we're looking at how to improve PD terminal care, since the main result we had previously was that treatment is often stopped, leaving patients with very uncomfortable symptoms and sometimes precipitating death. So Mathieu Béraud and Marc Vérin, the two neurologists of the study, they use apomorphine as a main in their clinical practice, which is not the case for everyone in France, far from it, in this specific indication. So we are trying to gather some field data first, and then the objective is therefore to have clinical trials in France. And also internationally, we are trying to raise awareness on the potential interest of apomorphine, knowing that it's not available everywhere as a continuous stimulation. In some countries, for instance, the US, is not available yet as a pump, but you can use it either sublingually or with the pen. So it's worth considering, I think, owing to the relative good safety profile we had on our patients.
Thank you. I had a question just come through, whether you could comment on the risk of nausea, precipitation in the last few days of life with this intervention, and what did you do if that did occur?
Yeah, that's a really interesting point, because we're used to see nausea in apomorphine treated patients, but in these specific cases of terminal care, it really never happened, even though when they were not able to take domperidone, which is the antiemetic that we use in France for apomorphine. So we have very relatively low level of nausea, not to say not at all, in our patients. And I think it's because the doses are quite low, and maybe the patient, I don't know, but the pharmacokinetic modification you can have at the end of life might account for that. But it's worth considering you can still use domperidone or another antiemetic that is administered not orally. So rectal domperidone or preparation you could use if you're very worried about causing nausea or vomiting.
One last question's come. Did you select people with specifically had terminal stiffness?
No, that's the main result we have with the use of apomorphine. The main result is it improved motor symptoms and mainly stiffness. But even in patients who did not have really symptoms showing off of rigidity, it was still useful. So we took into account the non-motor effects also of apomorphine for sleep, for instance.
Thank you very much indeed. That was very helpful.